Hi, everybody. We are here today with another National Blood Clot mini PEP topic. I'm joined with my PEP partner, Todd Robertson. And today we have as our clinical expert, Dr. Bethany Samuelson Bannow. Did I pronounce that correctly? Bannow, sorry. We're very fortunate to have you here. Our topic is actually going to be on heavy menstrual bleeding and anticoagulation. These mini PEP questions, these topics are based on questions and requests from information from the blood clot patient community that we serve. We want the NBCA patient community to know that we hear you, and we are working to provide the gaps in information that patients are experiencing. So I'm going to introduce Bethany now. And so thank you again for coming and joining us today. Bethany is a hematologist. She is a scientist and an assistant professor at the Oregon Health and Science University, where she is passionate about improving the care of patients with bleeding and clotting disorders. As a doctor at the Oregon Health and Science University Hemophilia Treatment Center and the Center for Women's Health, she focuses on treating patients with bleeding disorders. Bethany also specializes in the treatment of women with thrombosis, abnormal uterine bleeding due to anticoagulation or of unknown cause, and/or hematologic disorders affecting pregnancy. As a scientist, she works to better understand how the body regulates blood clotting in the uterus and the experience of women with heavy menstrual bleeding. She serves as a site principal investigator on multiple clinical trials for treatments of patients with hemophilia, von Willebrand disease, and other bleeding disorders through the hemophilia treatment centers. Bethany is also an assistant professor at Oregon Health and Science University's School of Medicine and Hematology. Wow. She lectures medical students, physician assistant students, and dental residents multiple times on the management of bleeding disorders. She gives invited talks around the country. I've been fortunate enough to actually listen to you a couple of times, and internationally on the diagnosis and management of heavy menstrual bleeding in women with bleeding disorders on anticoagulation. In addition, Bethany is a member of the American Society of Hematology, where she serves as an associate editor of ASH Clinical News, the Foundation for Women and Girls with Blood Disorders, which is a fantastic organization, where she serves as a co-chair of the Thrombosis Subcommittee and the Hemostasis and Thrombosis Research Society, where she also serves on the planning committee for the 2023 and 2025 meetings. Bethany also serves on the Hematology Item Writing Task Force for the American Board of Internal Medicine. She is married. She has one young daughter. She's another baby on the way. And she has a corgi named Duchess, which I love that you put that in there. Bethany has her MD from Oregon Health and Science University. She did her residency in internal medicine at the University of San Francisco and her fellowship in hematology and oncology at the University of Washington in Seattle, Washington. I cannot think of a better person to join us here today than you, Bethany. So thank you again for being with us. Todd and I are extremely informal, so we're going to go by first name basis. I'm assuming that's okay by you. We do so. Super. Okay, great. So let's get into this topic. So Bethany, we hear from many of our menstruating patients that they experience heavy bleeding during their menstruation cycle while on an anticoagulant. Is there an actual clinical diagnosis for this of heavy menstrual bleeding? And if so, what is it? Can you speak to us about the work that you're doing in the space? And I know this is kind of a multi-factor question for you, but does anticoagulation contribute to heavy menstrual bleeding? And if you forget any of the questions, we'll remind you because there's so many of them. And, really, what is normal versus not? What should the patient be looking for after starting anticoagulation? When should they be concerned about heavy bleeding? As a blood clot survivor, I experienced this firsthand and received no information whatsoever. So I'm going to turn it over to you to jump things off.
Great. Yeah. First of all, very just delighted to be here, be a part of it. Thank you very much for inviting me. I think these are really great questions. So the diagnosis of heavy menstrual bleeding in particular is interesting because there's actually been a change to that definition recently, which basically says any bleeding, period-related bleeding that decreases a person's social, emotional, physical, or financial quality of life qualifies as heavy bleeding. And so that is actually very easy because the patient diagnoses themselves in those scenarios. So basically what that means is that if bleeding bothers a menstruating patient, we should try to do something about it. Now, functionally, as a clinician, I do sometimes have to distinguish between heavy bleeding that can be harmful versus heavy bleeding that we need to treat for inconvenience just to make sure that we're not missing important things. And so factors that really raise red flags for me: if somebody has to change a pad or a tampon more often than every 2 hours, that's a flag. If they're passing blood clots that are greater than a quarter in diameter, if they have iron deficiency, those are all fairly diagnostic of heavy menstrual bleeding. There are other factors as well that raise our concern, though. So having to get up at night to change a product because you can't sleep through the night without leaking, having what we call flooding episodes, meaning just this kind of gushing sensation. Those are also things we worry about. We know now that a lot of folks are using alternative period products, which is actually part of what my work is on right now. And so I would just throw out there that if you are using a menstrual cup and you're emptying that more than twice a day on the heavy days, that also makes me worried. We actually consider that 80 milliliters of blood loss per cycle is heavy bleeding, and those menstrual cups can hold like 30. So you can imagine how quickly you can get up to 80 changing those frequently. So those are things that I want patients to look out for. Anticoagulation use absolutely contributes to heavy menstrual bleeding. So about 30% of the menstruating population will have heavy menstrual bleeding at some point, sort of regardless. Up to 70% or maybe even more of anticoagulated patients will have heavy menstrual bleeding. Now, that doesn't mean that the anticoagulation is the sole cause. Sometimes periods were normal before and they become heavy on anticoagulation. Sometimes periods have always been heavy. Sometimes there are other things that add on top of the anticoagulation, like fibroids or perimenopausal changes or things like that. So certainly it increases heavy menstrual bleeding, but we can't be too quick to just chalk it up to the anticoagulation. Sometimes we need to do more digging.
Interesting. I had fibroids and was perimenopausal. And so the combination of those two with an anticoagulant was very concerning for me. And like I said before, I received almost no information about being on an anticoagulant and having those two issues. So thank you for that.
Yeah, we don't talk about periods enough. I think there's also this idea out there that menopause, like periods, just like slow down and stop. And people don't realize they get worse before they get better. Yes. I mean, everybody in my clinic, I see a specific subset of patients. I'm sure some people it just does get lighter, but that's not universal. Yeah. So we need to warn people about that too.
Absolutely. I'm a card-carrying member of that club.
Yeah.
Okay. Todd, I think you had some questions.
Well, Bethany, I want to thank you for being here, number one. And thanks for letting me sit in because, guys have it a lot easier when it comes to this, right? But it's really important that men, whether it's husbands, boyfriends, friends, brothers, whatever, they need to have a better understanding of what their companion, wife, sister, what they're going through. Because it's a hard subject for men to grasp a hold of. So a big benefit for me is I'm learning, and now maybe I can communicate with some of these guys a little bit and try to, get across certain points because they do need to have a better understanding. So thanks for letting me sit in. There are different types of anticoagulants. Is there a difference in terms when it comes to heavy menstrual bleeding on one versus the other? So if a patient is transferring from like warfarin to say a DOAC or from even an injectable to warfarin, what should they expect?
Yeah, great questions. And I'm so glad that you brought up the point about men too, because I think the number one thing we need to do is erase the stigma around periods. Right. Like it needs to be something that we're all comfortable talking about.
That's right.
I think that will only change as a society if we get men on board with that. So glad you're here. Glad there are men out there committed to talking about this. We all came from a uterus. Whether we
That's
like
right.
to talk about it or not, we
That's
all
right.
came from one. So
That's right.
Absolutely.
there you go. It's important to us all. In terms of the question about different anticoagulants, so it's not so much a difference between the classes of anticoagulants as there seems to be some difference between specific drugs. And so rivaroxaban, I would say, is the worst of the bunch, unfortunately. We don't fully understand why that is. It's probably because by having once daily dose, we just have higher levels of anticoagulation in the bloodstream. And that can be a couple times, the risk of heavy menstrual bleeding can be a couple times higher than we see with the other agents. Warfarin, low molecular weight heparin, and apixaban all seem to be pretty similar. There's not great data. They're out on edoxaban, but not a ton of people are on edoxaban, so that's part of it. Interestingly, dabigatran, which is used more in the cardiology world, we don't really use it so much in the blood clot world, may be associated with a lower risk, maybe kind of roughly half as much as you would see with warfarin or apixaban. That said, there's no, I have patients on rivaroxaban who don't have heavy periods. I have patients on warfarin and apixaban with very heavy periods. It's a very individual thing. Right. It does seem that the first period after starting anticoagulation is the worst, at least of the next few periods. And so I think, changing between DOACs or between agents, I don't anticipate people will see a huge difference. They may, if they're switching from warfarin to rivaroxaban, for example. If they're switching from warfarin to apixaban, probably less so. But we also develop additional things over time. So folks could be approaching perimenopausal area. They could be developing fibroids. There could be other reasons for things to get worse. I do personally try to minimize rivaroxaban use in folks who already have heavy periods, but that's easier said than done because a lot of them are young, they have young children, and taking a pill more than once a day is just a real hard thing to do. So there's a lot of things to be kept in mind.
Yeah, and you brought up that, that first period or the first couple, that's when it really hits. And that's when we were talking just before the show a little bit about the emotional impact. I see in a lot of the patients where, those first times they're not expecting that. Maybe they weren't warned that was going to happen by their doctor, and they get very concerned and filled with anxiety. So I'm glad you touched on that too. Thank you.
Yeah, it can definitely be distressing. I think one of the issues that I see most commonly is in the group of folks who are menstruating and have clots, many of them develop clots because related to birth control. So they were on birth control for whatever reason. Maybe it was heavy menstrual bleeding. Maybe it was just to prevent pregnancy. They come in, they get the diagnosis. They get the very good news that they're probably not likely to have another clot again as long as they avoid estrogen. But then the pills get stopped at the same time the anticoagulant gets started. And that's just kind of a recipe for disaster, unfortunately. So we're kind of working hard to get the word out about, in certain circumstances, it's okay to continue on those while anticoagulation is started. So that would be a question I would say that patients can ask their providers. Am I a candidate for continuing that? And of course, there's a variety of other hormonal methods to control periods. The Mirena IUD is a great one. Definitely doesn't increase the risk of thrombosis. That can help manage those symptoms. But we need to do a much better job of preparing people and talking about periods when we start anticoagulation. I think there's a lot of reasons for it. I think we all think of 75-year-old men when we prescribe anticoagulation. The fact is, that's just not, that's not our patient population. It's not.
Yeah, anybody can get this. Absolutely. Yeah. So Bethany, if a patient presents with heavy menstrual bleeding, which I'm going to start referring to as HMB, what can they do? What are the options for them? Obviously I didn't want to stop my anticoagulation, but, people don't want to stop their anticoagulation for fear of getting another blood clot. Are there other physical impacts related to heavy menstrual bleeding that they should be aware of, such as the low iron levels? What is low? How do you get treated for that? And should all women menstruating or should all people menstruating that are on an anticoagulant get their iron levels tested?
Great questions. Yeah. So, in terms of what you can do, I think there's a lot of different options. Most of them are going to occur through a gynecology consult. So, getting a gynecologist that you trust right away, I think, is really important. And most of the options to control it are going to be hormonally based birth control type options, which can be very effective, can be safe in folks certainly on anticoagulation and even off anticoagulation. So I think that's something to know. Definitely don't stop the anticoagulation. There's some interesting data that show that patients on rivaroxaban who have heavy menstrual bleeding are up to 5 times more likely to have a recurrent thrombosis than those who don't have heavy menstrual bleeding. And the study didn't really dive too deeply into it, but our suspicion is that folks were having terribly heavy periods. They weren't warned about it. They were afraid to talk about it, and they held their pills for a few days, and that's what led to it. So I don't know that for sure. That's, a hypothesis that has yet to be tested, but it's kind of the most logical explanation. So definitely don't stop it. If it's worrisome, call your doctor, go to an urgent care, go to an ER if you need to. The first thing, we want to make sure that somebody's not having severe anemia, meaning low red blood cells, because that would be the potential emergency in this case. But yeah, I think probably, pretty much anybody who has heavy menstrual bleeding is likely to have iron deficiency. And so I do check that routinely on my patients. So I try to check it at the time of the first prescription for the anticoagulant, if I'm involved then, to get a baseline. And then I usually check it every 3 months in somebody who's menstruating on anticoagulation. And if you go to a year without needing iron supplementation, then you can check it less frequently. But I do like to keep an eye on it up front so we can make sure that we're getting folks treatment, either oral iron supplementation or IV iron supplementation when needed. Either can be effective, but it is a good thing to stay on top of. There's also some interesting data that iron deficiency may contribute to bleeding risk. It's not been done specifically in folks on anticoagulation, but they have done studies of platelet function, and platelets being the part of the blood that help you make a clot. And platelet function seems to be less in iron deficient patients. So another really good reason to try and stay on top of it.
How interesting. I've not heard that before.
It's all in a lab. It's just one study right now, but it happened. It was studied at OHSU, so I'm kind of privy to it, but it's definitely, got me focused on the iron even more.
Yeah. So when you get that information, please share it with us so that we can share it with our patient community. I was one of those patients who my iron level was very low.
Yeah.
And while I didn't have to get treated in an injectable format, I definitely did have to take iron pills to supplement, and it made a big difference for me. So thank you. Thank you for that.
Yeah.
Hey, Bethany, a woman at different points, I've been thinking about this, and you touched on it a little bit, but a woman at different points in their life may experience different menstrual cycles, such as perimenopausal individuals who might have a heavier menstrual cycle. Should they be treated differently? Or for a woman who might have fibroids or even cancer, what is the protocol? And you did touch on this a little bit, but it'd be nice to recap. Will all women suffer from heavy menstrual bleeding if on anticoagulants? I know, it's a very individualistic thing. So you did touch on it before, but maybe recap on that. And something I've always been curious to, is there a difference by race? And in the case of DOACs, is it somewhat dependent on the dosage that's actually prescribed?
Yeah, those are great questions. I would say, the fancy doctor word for this is multifactorial. That just means there are many factors contributing to heavy menstrual bleeding. And so, yes, absolutely. Just because a patient is on anticoagulation doesn't mean they're exempt from fibroids or cancer or changes with perimenopause. I think it's, the bottom line is it's just important to be established with a good gynecologist that you trust, who can help walk you through these things. Depending on when the changes happen, how they happen, how bad things are, the age of the person, it may be that an ultrasound is needed to look for fibroids, or a biopsy is needed to look for cancer. That's a very individual thing. And I think, as much as patients can be aware of their own body and their changes in their body and keep in contact with a gynecologist, I think that's really the key. Certainly, cancer, the treatment is usually going to be hysterectomy. With fibroids and even heavy menstrual bleeding in general, there are actually a few surgical or procedural options for folks who are done having children. So if somebody wants to preserve fertility, we don't go down this route, but different options include an endometrial ablation, which is where they kind of go in and they zap the lining of the uterus called the endometrium, and that can really reduce or stop periods for months or years at a time. There's something called a uterine artery embolization, where they put little bits of safe plastic in the arteries that feed the uterus that can be effective for fibroids. There can also be surgeries that remove the fibroids directly or the uterus altogether. So there are a lot of options there. In terms of, the difference between race, I want to start off by saying that we are finally beginning to say out loud what we should have been saying for a long time, which is that race is really a surrogate for other factors. There's really not evidence to say that genetically people of different races have significant differences. Occasionally, some things are more common in people of different heritage, but really it seems to be a marker of things like socioeconomic factors, systematic racism, things like that. And so those certainly contribute to overall health, but it's a society problem. It's not a skin color problem. I just want to be clear about that.
Good point.
And so within that, so we do know that Black women are at higher risk for fibroids. Up to 80% of Black women will have fibroids by kind of the menopausal time. And so that could certainly contribute. I don't think we have good data on differences in bleeding in folks on anticoagulation. I will say that women in general have told us and have shown, we've seen in the literature, that they're not listened to as well as they should be. So a lot of women, I think, go under the radar and don't get diagnosed like they should. And I think that's probably doubly true for folks of color. So I think there's a lot of factors that could contribute to that. I think, we as healthcare providers need to make sure that we are addressing this in all of our patients and really building trust so we don't let these things slip through the cracks. In terms of dosage, the question, so there's not a ton of data on this. There was really only one study where they looked at rivaroxaban full dose, so 20 milligrams daily versus the prophylactic dose, which is 10 milligrams daily. And they didn't really find a difference. Now, all of those folks had already been on anticoagulation for a few months, because we don't usually start people out on 10 milligrams daily, but it didn't seem to make a huge difference. It may or may not make a slight difference in the individual, but I think very rarely is changing the dosage gonna be the answer to any problem.
Okay, great. You answered all those questions. Thank you.
Yeah,
that was fascinating. Okay, so, and Todd, great questions. We're so glad that you're actually here today with us. So
I am too. It's I love learning. Knowledge is power. And,
absolutely.
And being on the outside, by being a man, I've never had a problem listening to these stories. I've always felt very helpless because I didn't know how to respond to some of these, and learning from you and being here just makes that tool for me more powerful. So thank you.
And you, as the conduit to the patient community, you are now going to be in a position to share this information and be comfortable fielding questions and normalizing this.
That's right.
So that people can just talk freely about it and not have some weird stigma associated with this, because we all need to get past that.
That's right.
Okay, so let's do just a little bit of a recap, Bethany. Again, for those that are experiencing HMB, what are the treatment options for heavy bleeding? And then we often hear from patients that their doctor actually never spoke to them about this issue. Let's recap when the patient should seek help and what type of questions should they ask of their healthcare team, and who should that team be, because you're a hematologist, but clearly there's a role for a gynecologist. So who actually should be involved in this process? And why do you think this issue is not addressed?
Yeah, so those are great questions. So in terms of the treatment of heavy menstrual bleeding, there's really three overall categories. So one of them is the hormonal therapies that can include birth control pills, Mirena IUD, and other sort of forms of hormonal contraception. The second one is procedural options like we discussed, so things like endometrial ablation, hysterectomy if needed. That's usually a last resort. There's a third one we didn't really talk about today. It's called tranexamic acid. It's what we call an antifibrinolytic, which means it slows down the process of breaking down a clot, which is very active in the uterus. I have occasionally used that in patients on anticoagulation, but it's not something we want to use in the first month to 3 months after a clot. So that is something that folks can consider down the line, but I didn't want to focus too much on that because this isn't really the population that it's ideally used in unless it's needed. And yes, I think absolutely lots of doctors don't talk about this. I think there's a whole lot of combinations of reasons for that issue. I think there's stigma around it. I think there's people not used to talking about it because, again, they picture the 75-year-old man when they prescribe the anticoagulation. I think there's sort of the circumstances in which it's prescribed in. So if somebody is coming in with a blood clot in their lungs and they're very sick and it's potentially a life-threatening issue, then people probably aren't going to focus on the periods too much at that time. Or if it's in a really busy ER and they've been waiting for 8 hours to get their treatment and everybody wants them to be able to go home and get out of there. I think there's a lot of reasons, and I think that's why it's important to for patients to touch base with their primary care provider. So certainly plenty of patients with anticoagulation are seen by hematologists, but not all patients on anticoagulation need hematologists. Primary care doctors, family practice doctors, internal medicine doctors, they can all prescribe it and should be comfortable with it. And so talking to them, talking to a gynecologist, they should also be on the team if there's menstrual bleeding, not only to talk about heavy menstrual bleeding, but also to talk about effective contraception, because we really recommend against pregnancy in the first 3 months after a clot. Because the risk is higher of recurrence then.
Yeah.
And you might want, and also talking to, if there is pregnancy planned in the future, talking to an OB or a hematologist about how to manage that. So I think a gynecologist is really an essential part of that team. In terms of what questions to ask, I think it depends a little bit on the circumstance. You can ask, this is what my period is like. This is how many days it lasts. This is how often I change my pad or tampon. Is that okay? Is that normal? That's always a good question. You can ask, am I anemic? Am I iron deficient? And that's going to require some labs to figure out. If it's affecting your quality of life or causing you worry, what's the best thing for me to do about this? I would say are important questions to ask.
Great. This is really such a fascinating topic. I could listen to you talk about this probably for the next day, but
yeah, and it's not talked about enough. So yeah. That's why this is going to be so impactful. And a lot of these PEP talks that we do, that's what we're doing, is we're putting out information and conversations that just really are not out there, especially with the patients involved. And, that's going to help with that one area that you were talking about where I get so frustrated and it happens with both men and women, where we are sometimes dismissed at the doctor's office when we have anxiety about something, but I see it overwhelmingly happening to women. And I find it so frustrating. And I get so angry about that when they just get dismissed and told, it's just this or it's just that, anxiety, whatever. It's like, no.
It's in your head.
It bothers me when I hear that from patients. So, and having this open conversation, maybe medical providers and other people will be able to hear that, look, this is a problem. Let's work on it. We've got to have a foundation. And I think that when it comes to this menstrual stuff, I think this is a great source of information. And I'm just so happy that you were here, Bethany, and that I got to sit in. So thank you very much for being here.
Thank you. It's my pleasure. And I'm in a position now where I really only see people who can, will, or do menstruate or become pregnant. And I got to tell you, they're some of the toughest people I've ever met who go through these circumstances and deal with the bleeding and deal with the clots. And, definitely anxiety is a symptom. It's something that happens after this.
Absolutely.
And it's not without reason. So, yeah, we're working.
Are there clinical guidelines on this issue, or is there just guidance at this point in time?
In anticoagulation, there's just guidance at this point. The gynecologic societies do have some recommendations for the diagnosis and treatment of heavy menstrual bleeding. in general, that has to be modified a bit for the anticoagulated patient because, tranexamic acid is a first line. If you don't have a clot, not going to be an appropriate first line for everybody with a clot, although it might be appropriate for some patients. And there's certainly nothing right now, unfortunately, in our hematologic guidelines. I would love to see that. I give lots and lots of talks about it, but nobody's asked me to write a guideline yet. So maybe someday.
There's definitely a need for it. So maybe we can help you move the needle on that one, because there's definitely a need for that.
Yeah.
Echoing Todd, we want to thank you for coming on today and answering these questions. And we're excited to be able to share this with our patient community. This is just such an incredibly important topic, and we want to normalize this so everybody feels comfortable talking about this. We'd like to give you the final floor. And if there's anything else that you'd like to share with patients, and for that matter, clinicians also, please take the opportunity now to do so.
Awesome. Well, thank you so much for having me. I'm just delighted to work with you. This is such a great organization. You do such wonderful work for patients and providers and all that. I mean, I would say talk about it. Talk about periods. Talk about periods in the clinic. Talk about periods with your family. Talk about periods with your friends if you're comfortable. The only way we're going to make any progress on this is if people get comfortable talking about it and realize what's normal and what's not normal. And so I think, we can make huge progress just by ending the stigma.
Yep.
Absolutely. And inviting more men to participate in the conversation.
Absolutely.
That's right. That's right.
All right. Thank you both for joining today. And we look forward to having you back to continue this conversation.
Yeah, that'd be great.